Hi friends, this is Srinivas Samavedam. I'm one of the administrators of the Higgs WhatsApp group and a member of the Kriti learning group as well. 2 weeks ago, I spoke about arterial blood gas analysis in a brief summary, and today I'll try to take you through to another common problem sometimes which gets us into trouble in the intensive care unit, and that is hyponatremia. The first and foremost principle of understanding hyponatremia is the fact that sodium imbalance is intrinsically linked to imbalance of water homeostasis. So you cannot think about or you cannot treat sodium imbalance without addressing the associated water imbalance. Whether it is hypo or hypernatremia, it is an intrinsic association of water imbalance which is linked with sodium imbalance as well. The main mechanism of sodium balance in the body is by renal sodium excretion. So if you understand that renal sodium excretion is linked to the countercurrent mechanism and the tonicity of plasma due to its predominant extracellular presence, the changes in sodium concentration influence the extracellular volume. So you can have a patient who has a sodium disturbance. You can assume that the patient also has a change in the extracellular water, either hypo or hypervolemia. Any change in the volume status of a patient, whether hypovolemia or hypervolemia, triggers a change or triggers mechanisms for either renal excretion of sodium or renal elimination of sodium or renal conservation of sodium. So the first thing we need to understand when you want to treat hyponatremia is to assess the volume status of the patient and try to correct it, whether it is hypovolemic, it is euvolemic or hypervolemic. The second point you need to understand is what is the true definition of hyponatremia. Textbooks define a sodium value of less than 135 milliequivalents per liter as hyponatremia, but this value of less than 135 does not usually produce any symptoms of hyponatremia. The symptoms of hyponatremia begin to appear when the sodium falls below 125 milliequivalents per liter. And severe symptoms of hyponatremia like cerebral edema with or without raised intracranial pressure can happen when the sodium drops below 120 milliequivalents per liter. But it is not the absolute number of sodium that makes a difference or that influences the manifestations. It is the rapidity of onset of the hyponatremia which has an effect on the severity of symptoms. This is because the more rapid the change in sodium, the more rapid will be the extracellular change, the changes in the extracellular fluid shifts, and that is what causes the manifestations to come very fast. Like carbon dioxide retention, adaptation to sodium imbalance takes about 48 hours to set in and neutralize. So if somebody has been hyponatremic for more than 48 hours, you can actually label them as chronic hyponatremia. The more significant and severe clinical signs of hyponatremia are encountered in the acute forms of hyponatremia, and there are various manifestations. Predominantly they are neurological manifestations, but you can also have patients who have cardiac manifestations like PR interval prolongation, ventricular arrhythmias, and sometimes you can also have coagulation abnormalities associated with hyponatremia. But the most important thing you need to understand with hyponatremia is that the severity of hyponatremia are usually associated with the rapidity of development of the symptoms of the hyponatremia, as I said. So you can actually grade hyponatremia as moderately severe hyponatremia and severe hyponatremia. Patients who have moderate or moderately severe hyponatremia usually have nausea without vomitings. They usually have headache and are confused. So they lose the orientation of time and place. When this hyponatremia progresses to a severe hyponatremia, that is when you get seizures, the abnormal mentation, a GCS of less than 8, and sometimes you can get a cardiac arrest also as a result of hyponatremia. But when you try to approach these patients, you need to have a very meticulous and very structured approach to the diagnosis and management of hyponatremia. As with most aspects of clinical medicine, the diagnosis of hyponatremia should begin with a very detailed clinical history. Has there been any gastrointestinal fluid loss? Has there been any exertional fluid loss for the patient? Has the patient been on thiazide diuretics for a long period of time? Or was there any other disease which can predict, suggestive of a coexisting disease which can be associated with hyponatremia, like a thyroid dysfunction or something that predisposes to adrenal insufficiency? Disorders of renal, endocrine, cardiac and gastrointestinal systems contribute to hyponatremia in good number of patients. Up to 35% of patients will have either renal, endocrine, cardiac or gastrointestinal disturbances like chronic liver disease or something like that. Disorders of respiratory and CNS systems can produce hyponatremia by a peculiar entity called syndrome of inappropriate antidiuretic hormone production. For example, previously patients with pneumonias were considered to be prime candidates for SIADH. Patients with neoplasia, for example, with paraneoplastic manifestations, patients with meningitis, patients with subarachnoid hemorrhage, traumatic brain injury. These are all patients who are predisposed to hyponatremia due to a variety of causes which we will talk about in the due course of this presentation. Apart from thiazide diuretics, you also need to ask about antipsychotics and anti-Parkinson's medications. These are essentially very important drugs which can trigger either SIADH or a tubular toxicity causing loss of sodium in the renal tubules. So drug history is an important aspect of an approach of a patient with hyponatremia. Once you know that, the treatment of hyponatremia should proceed further only after the assessment of serum and urine osmolarities. This is a very important step which is often overlooked in the workup of hyponatremia. The effect of hyponatremia on serum osmolarity has to be interpreted in the overall context of the volume status of the patient. And most situations of hyponatremia are associated with obvious evidence of hypo, U or hypervolemia, and that needs to be understood. And it is also possible that a patient being treated for a specific type of hyponatremia might develop another type of hyponatremia as a result of the therapy per se. So every interpretation of a low sodium value while you send off the labs for serum osmolarity and urine osmolarity, the first thing you need to be looking at is, am I dealing with a pseudo-hyponatremia? What exactly is this pseudo-hyponatremia? Pseudo-hyponatremia is a lab abnormality which shows up as a low sodium despite the body sodium content being normal. And several clinical conditions including hyperglycemia, hyperlipidemia, paraproteinemias and the use of mannitol are associated with a low value of sodium, with the osmolarity and the volume status of the individual being normal. A low serum sodium value with a normal osmolarity, normal volume status of the patient and normal urine sodium should raise suspicion of a pseudo-hyponatremia. So if you have a patient who is showing low on the lab report for sodium but has a normal osmolarity and normal urine sodium excretion and a normal assessment of volume status, should probably be screened for conditions which produce pseudo-hyponatremia. Similarly, when a patient is hyperglycemic above a blood sugar of 250 mg per deciliter, you should correct it for the sodium, correct the blood sugar and the sodium, so that you actually treat the true hyponatremia and do not overreact to pseudo-hyponatremia. In a patient who is hyperglycemic, so if you have a patient whose blood sugar is more than 250, you measure the sodium and the corrected sodium is equal to the difference between the blood sugar minus 100 multiplied by 0.016 and then you add that to the serum sodium. So usually in a patient who has a 400 blood sugar, you will have an increase of 3 to 4 milliequivalents per liter in the hyponatremia. Hypovolemic hyponatremia is by far the most common cause of hyponatremia that comes into intensive care units, and there are numerous conditions which can result in this hypovolemic hyponatremia. In tropical countries, diarrheal disorders are very common and gastrointestinal fluid losses and diuretic use are well documented. Added to the fact that thiazide diuretics are an integral part of antihypertensive medications, and hypertension is a big problem in India, and you will find a good number of patients on a combination of either calcium channel blockers or angiotensin receptor blockers or ACE inhibitors with a combination of thiazide diuretics, and that's an important cause of hypovolemic hyponatremia in this patient. It's a depletional kind of hyponatremia. In patients in the neurointensive care unit, excessive use of mannitol can cause hyponatremia, and a peculiar condition called cerebral salt wasting can also result in hyponatremia. In critically ill patients coming into the intensive care unit for totally unrelated causes, mineralocorticoid deficiency can also be an integral part of hyponatremia workup when you are not actually finding the cause of hyponatremia. Sometimes you will also find third spacing, which is also a form of hypovolemic hyponatremia because the fluid is elsewhere, and this happens either in Burns patients or in bowel obstruction patients, which can be one of the causes of hypovolemic hyponatremia. Hypervolemic hyponatremia, probably if you are working in a cardiac center, you would know that this is a very common cause. So we won't be, and it's very obvious. Similarly, if you have a very huge CKD load, maybe you know that it causes hyponatremia, but so it's a very obvious cause. The two important things we should be able to understand and interpret is euvolemic hyponatremia, especially in the context of syndrome of inappropriate antidiuretic hormone production. This type of hyponatremia, that is euvolemic hyponatremia, if the patient's volume status is normal, is probably the very most subtle type of hyponatremia and is most often missed, and it is therefore difficult to identify in critically ill patients. Excessive exercise, hypothyroidism, adrenal insufficiency, poor dietary intake are all implicated in the pathogenesis of euvolemic hyponatremia, and you need to exclude these causes before you think about the patient having a syndrome of inappropriate antidiuretic hormone production. Very specific cohort of patients have psychogenic polydipsia, and excessive water intake can also result in euvolemic hyponatremia. It does not cause hypervolemic hyponatremia. The syndrome of inappropriate antidiuretic hormone production, SIADH, is labeled as inappropriate since the ADH production occurs independent of the circulatory volume and effective osmolarity. Generally, you expect the antidiuretic hormone to be linked to the volume status of the patient and therefore the effective osmolarity. But if this production of ADH is inappropriate to the volume status of the patient and the effective osmolarity, you call it as SIADH. This antidiuretic hormone production could usually come from the pituitary, but it can also come from ectopic sources. That is the pathophysiology in which SIADH happens in patients with bronchogenic carcinoma, non-small cell variants. Most frequently, this is occurring from ectopic cancers like small cell carcinoma of the lung, or in conditions like respiratory CNS infections, TB, meningitis, subarachnoid hemorrhage, or and sometimes in hospitalized patients. Those who look after surgical intensive care units should be very careful that inappropriate analgesia to a perioperative patient can trigger the production of ADH from the pituitary and trigger hyponatremia due to syndrome of inappropriate antidiuretic hormone production. But most importantly, the diagnostic criteria of SIADH needs to be remembered, and the diagnostic criteria for SIADH are very simple. You have certain essential criteria and you have supplemental criteria. The essential criteria for you to make a diagnosis of syndrome of inappropriate antidiuretic hormone production is that there should be an effective serum osmolality of less than 275 milliosmoles per kg, and you should have a urine osmolarity of more than 100 milliosmoles per kg at some level of decreased effective osmolarity. Clinically, the patient should not be volume depleted or volume overloaded, and the urine sodium concentration of more than 30 millimoles per liter with normal dietary salt intake and water intake and no administration of hypertonic saline. Most importantly, you should exclude the presence of adrenal, thyroid, pituitary and renal disease like hypothyroidism, adrenal insufficiency and CKD. As I said, the use of thiazide diuretics will preclude you from making a diagnosis of syndrome of inappropriate antidiuretic hormone production. These are the essential criteria. There are certain supplemental criteria which are not very commonly understood but were very important when the differentials are being thrashed around. Is that a serum uric acid should be less than 4 milligrams per deciliter and the urea should be less than 21.6. This actually rules out a renal dysfunction as the cause of syndrome of inappropriate antidiuretic hormone production. And sometimes you give saline to these patients, 0.9% saline. If you don't correct it, if you are not able to correct the sodium, it then becomes a supplemental criteria for you to make a diagnosis of SIADH. The fractional excretion of sodium should be more than 0.5%. The fractional excretion of urea should be more than 55%, and the fractional uric acid excretion should be more than 12%. And when you restrict fluids, the sodium should start increasing. This is one of the supplemental criteria for making a diagnosis of syndrome of inappropriate antidiuretic hormone production. So, when you have a patient who is hyponatremic, how do you treat it? The acuity of onset of sodium, as I said before, is a vital determinant of the rapidity of correction. The compilation of the most important concern which most of us have is about osmotic demyelination. So, the so-called pontine and extrapontine myelinolysis. It is most often seen among patients with chronic hyponatremia, which has been corrected too rapidly. But there are certain subsets of patients who are more prone for osmotic demyelination, and we should be very careful when we look at correcting sodium in such patients. The risk factors for osmotic demyelination are the alcoholic patients, the patients who are malnourished, like pancreatic pathology, or those who are cachectic because of disease or debilitated because of immobility, patients who are hypokalemic, burns patients, patients who had previous hypoxic episodes and structural brain injury, patients who are on thiazide diuretics, the female gender, especially the elderly female, and patients who have a plasma sodium of less than 105 milliequivalents per liter. These are the patients in whom you have to specifically be very careful about the osmotic demyelination syndrome. But remember that osmotic demyelination can happen per se with hyponatremia. It can also happen with hypernatremia also. It is not an exclusive domain of rapid correction of sodium only. Importantly, symptomatic hyponatremia is a medical emergency, especially if the patient is mentally uptended or is seizing actually due to its neurological consequences. Therefore, the first question that needs to be answered when you are correcting sodium for these patients will be, is this hyponatremia symptomatic and is it acute or chronic? The correction has to be achieved in patients with symptomatic hyponatremia. The treatment has to be very rapid, and people have given such patients should be attended to in the monitored environment of a neurointensive care unit or in an intensive care unit, and there should be a prompt intravenous infusion of 150 ml or 2 ml per kg of 3% saline over half an hour. That is the rate at which you can give, and you need not be concerned about osmotic demyelination because this is a life-threatening complication and neurologically the patient is being compromised. This should be the first step in the management, and then you repeat the assessment at the end of the infusion to achieve an increment of 5 millimoles per liter. Yes, we know that we should not achieve more than 8 milliequivalents per liter in a day, but in symptomatic hyponatremia, which is life-threatening, you can stretch the target to 10 milliequivalents per. A target of 10 millimoles per liter in the first 24 hours and 8 millimoles per liter in the subsequent 24 hours is a safer way of correcting in severe symptomatic hyponatremia, that is the revised targets. And the formula for identifying the sodium deficit, you know the formula, so you have to know the total body weight of the patient. So if you know the serum sodium deficit, you set yourself a target. What is the sodium you want to be? Usually you keep it around 130. So you measure the total body, you calculate the total body water, which is probably the body weight of the individual into the a factor of 0.6 for adult men and 0.5 for adult women, you get total body water, and substitute in the formula. So the increase in serum sodium by any fluid is given by the infused sodium minus the serum sodium divided by the total body water plus 1. With this you will know how much saline you have to give, and you have to target an increase of 10 millimoles per liter in the first day and 8 millimoles per liter in the next 24 hours. Lastly, I will talk about the use of vasopressin antagonists, that is conivaptan and tolvaptan. They have been approved for the treatment of severe hypervolemic and euvolemic hyponatremia, and patients who have severe heart disease and chronic liver disease will show usually a very quick rise in sodium levels with the use of tolvaptan. And it is also evident among patients with syndrome of inappropriate antidiuretic hormone production. But patients with acute hepatic failure and subacute hepatic failure are not candidates to be treated with vaptans, although hyponatremia is an independent determinant of severity of the disease in these patients. So, in summary, all I can say is that hyponatremia is a medical emergency. It is symptomatic. It can produce non-neurological manifestations also. You need to exclude pseudo-hyponatremia. You always have to do it with the assessment of the volume status of the patient. So, if you ask me the clinical approach, what are the steps to the patient? You should confirm that the patient has a truly hypoosmolar state. You check for the severity of hyponatremia. You identify the duration of the onset of symptoms and rule out chronic hyponatremia. Assess the volume status. Check the urine osmolarity. See the serum osmolarity. Identify any treatable cause of hyponatremia like diuretic use and malignancies and meningitis or other infections. Withdraw implicated or causative drugs. Treat it as per the correct formula. You know the risk factors for osmotic demyelination, to also watch out for them, and always make sure that you are not denying a patient aggressive correction of sodium when the sodium is life-threatening. Thank you very much. I'm happy to see your comments and queries on this talk, and I'm happy also to hear from you what topic you would like to hear next time. Thank you very much.